Now it's my pleasure to introduce Dr. Girija K, who is Senior Consultant and Head of the Department of Glaucoma in Little Flora Hospital. She'll be speaking on surgical treatment of angle closure disease and a very interesting topic of role of early cataract extraction in glaucoma patients.
Good morning, everyone. Surgical treatment of angle closure glaucoma and role of early cataract extraction. So, as all of you know, the PSEG is a leading cause of blindness and it's more prevalent in Asia. So, the treatment options available are lasers primarily. So, initially we treat all the cases with occludable angles where there is more chance of progression. We always consider laser and the surgery comes later only. So, what are the indications of surgical treatment? When the eye has been treated with lasers and medical treatment is being continued because the IOP is uncontrolled, but the glaucoma is progressing. And when the angle closure or the pass is progressing despite a successful LPI, and when the patient is showing a poor compliance to the medical treatment, or when patients cannot cooperate for the laser treatment, you have to think of surgery. So what are the, if LPI is not possible, then you have to think about surgical iridectomy in certain situations. That is an acute angle closure glaucoma patient when there is unresolved corneal edema, but the patient is, the IOP is not at all controlled, or if an uncooperative patient for glaucoma, then non-availability of lasers in the center, corneal opacification limiting the view of the anterior chamber. Then in certain post-retina surgery patients, even if you do laser iridotomy, it keeps on closing. So you may have to repeat it multiple times. So in that case, you can consider a large surgical iridectomy. Then it can be combined with other surgical procedures like trabeculectomy, phakic IOLs, DSEC, all these procedures. When in order to prevent pupillary block, you can do a surgical iridectomy. Then along with biopsy of iris or ciliary body lesions and optical iridectomy. So after surgical iridectomy, the next option is a goniosynoculolysis. It's not very frequently done. It is usually, it can be performed along with the cataract extraction where you can mechanically strip the pass away from the trabecular mesh using viscoelastics or an irrigation cyclodialysis patella. But usually I've seen that it is not very effective because the synechiae formation recurs, because the inflammation is still there and the synechiae reforms. Then GDD in very chronic angle closure glaucoma with failed trabeculectomy, but in an angle closure glaucoma again the risk is more because the limited space is there, so the tube can get occluded with iris, or you can get corneal decompensation because the space is very less. Then in angle closure glaucoma eyes with end-stage disease, if the patient is symptomatic with a poor visual potential, you can consider CPC. So trabeculectomy is the usual surgical treatment for an angle closure glaucoma which is uncontrolled with medical treatment and status post LPI. So the procedure, the steps are the same as in open angle glaucoma, but one thing you have to be sure is that you do a surgical iridectomy here in order to prevent postoperative complications like malignant glaucoma, because nowadays the tendency is to avoid an iridectomy along with the trabeculectomy. So, but in an angle closure glaucoma, always do an iridectomy. And always it's better to use intraoperative mitomycin because these eyes will have a low-grade inflammation and the chances of failure of trabeculectomy is more. Suppose the patient is having glaucoma and cataract, then whether to do a phaco trap or a phaco alone, the debate is there. And you have to consider, I think Dr. Roni has explained to you, the angle closure glaucoma which is status post LPI, but with the cataract, with a controlled IOP, you can do a phaco alone. But uncontrolled IOP, you can either do a phaco trap, but suppose the IOP is very high, then it's better to do a trap than follow it with a phaco. Without cataract, with a controlled IOP, you can continue the medications. And uncontrolled IOP, without cataract, again you can do trap or a clear lens extraction. But in controlled IOP, if the patient is on maximum medications, it's always better to do a phaco trap. Risk factors are, again, Dr. Rooney has mentioned them, the aging changes, like an increase in thickness, increase in the lens vault, in the weakening of sonules, then changes in the iris features. All this will lead to a shallowing of the anterior chamber, increase the iridotrabecular contact and pupillary block, and it will block the aqueous outflow. So when you do a lens extraction, it will relieve the pupillary block, it will deepen the anterior chamber, it may separate the PAS, and it will increase the outflow. Along with that, it will increase the visual acuity also. So these are it's a meta-analysis of 5 randomized controlled trials comparing phaco-emulsification versus phaco-trab in PACG. So it was found that a consistently greater IOP lowering effect was seen in phaco-trab, and lower number of AGMs were needed postoperatively, but risk of complications was higher when you combine a trab with a phaco. This is another meta-analysis where 16 eligible trials were included, 5 randomized control and 11 non-randomized, and the patient sample size was very large. It found that the IOP control is greatest for phaco-trab, followed by trab, and then phaco. But the deepening of the anterior chamber depth was there whenever you do a cataract extraction. Along with that, the visual acuity also improved when you did the cataract extraction, but the outflow facility increased in all 3, and the surgery success rate was similar. So phaco-trab was found to be superior than the other 2 surgeries in IOP control, the chamber depth, visual acuity, and adjunctive therapy. But trab is superior than phaco, not phaco-trab, in IOP control, but it had more complications. Now coming to the role of lens extraction. It can be a clear lens extraction or an early cataract lens extraction. So first I will mention the EAGLE study. It's a randomized controlled trial which compared the efficacy, safety, and cost effectiveness of clear lens extraction versus LPI as the first line treatment of primary angle closure glaucoma, angle closure and angle closure glaucoma. The patients 50 years or older with no cataract and IOP more than 30 millimeters with PAC or PACG was included. 419 patients included, 208 underwent clear lens extraction and 211 underwent standard care with laser iridotomy. 36 months after treatment, it was found that the mean IOP was 1.18 millimeters lower in the lens extraction group, and the quality of life according to the QOL 5D questionnaire was greater, and it was also found to be cost effective. These are all various studies comparing it or doing a cataract clear lens extraction alone for for angle closure glaucoma. So how does the IOP rise? Intraoperative mechanisms. So injection of viscoelastic, the force fluids, increasing the hydrostatic pressure, the lens extraction, putting the IOL in the bag, all these will deepen the anterior chamber, it will open the pass and it will open the trabecular meshwork and increase the outflow. Along with that, the release of prostaglandins, interleukins, etc. also play a role. The clear lens extraction will relieve the pupillary block and it will also remove the plateau iris component. So what is the effect of cataract surgery on intraocular pressure reduction? There is a reduction of 1.5 to 3.5 millimeters over a period of 1 month to 3 years in normotensive eyes. But the reduction has a linear correlation with preoperative IOP. If the IOP is more, then the post-operative IOP reduction was also found to be more. This was supported by the Matsumura et al. Study and also the ORT study. So the pros and cons of clear lens extraction is that it was based on the low surgical complications, but always remember the unforeseen complications like PCR, malignant glaucoma, etc. Always the short eyes with narrow angles present challenges to the surgeon due to all the anatomical peculiarities, but take thorough precautions, do a thorough preoperative workup, use OVDs and prevent anterior chamber collapse, and always tamponade the anterior bulging curvature of the capsule before doing rexus. Always take care that a hydrodissection is not forceful, because it can lead to a blowout of the posterior capsule, and take all the due precautions and you can prevent the complications. But the question remains, can we advocate a primary role of cataract surgery in eyes with glaucoma over the entire glaucoma spectrum? So is clear lens extraction a solution for angle closure glaucoma? The debate continues. Thank you.